Welcome everyone to the first panel of the forum, and thank you for making the time to attend this session. The topic for this morning's panel is women's health, building support for women during and after pregnancy. My name is Joyce Adams. I'm a visiting assistant professor of global health in the Keough School of Global Affairs and affiliated faculty in the Keough Institute for Global Health. I am the moderator for this session. Before we begin, I would like to thank Notre Dame Research, the Health and Wellbeing Initiative, the Notre Dame Office of Clinical Partnerships, the Social Determinants of Wellbeing Taskforce, and everyone else who played a role in convening and supporting this community-focused research forum. Our panelists this morning will be speaking to us on maternal newborn health, and this is a research passion of mine. My research is focused on promoting postpartum health outcomes among women most vulnerable to maternal mortality. We have two great panelists who will be speaking to us about providing support to women both during and after pregnancy. Our first presentation is titled, "Is Breast Always Best? The Impact of Breastfeeding on Infant Health in a Predominantly Low-Income Population," to be presented by Dr. Sarah Kroeger and Dr. Kristen Cornelson. Dr. Kroeger is a research assistant professor at the Wilson Sheehan Lab for Economic Opportunities, and Dr. Cornelson is an assistant professor of economics. Immediately following that presentation, our second presenters, Dr. Kathleen Sobiech and Kristen Cornelson, will be presenting on holistic support for pregnant, birthing, and postpartum women during COVID-19 and beyond, a coalition building forum. Dr. Sobiech is an adjunct assistant teaching professor in the Master of Global Health program, and Ms. Jewett is an alumni of the Master of Science in Global Health program. There will be a dedicated time for questions and answers immediately following both presentations. So if you have any questions during the presentations, please type them out into the everyone chat box. This chat box will be monitored by moderators. Please do not send your questions into a private chat, as those will not be monitored. Feel free to type your questions into the chat box at any point in time during the presentations and discussion. And we'll have a dedicated time after both presentations to answer your questions and also have a great discussion. If your question is addressed to a specific panelist, you can say so, or you can address it to everybody else. If we run out of time or we do not have enough time to answer all of the questions in the chat box, there will be opportunities to follow up with the panelists. Also, the recording for this panel session will be made available. And so at this point, I'd like to hand over to Dr. Sarah Kroeger.
Hi, good morning. Thank you so much, Joyce and Bob, for kicking us off. And of course, I want to thank the organizers for this forum. I'm also very excited to hear about everyone's discussion and the other presentations. So I'm going to try hard to keep this part of the talk to 10 minutes. Okay, so I'm going to share my screen and hopefully this works. So as Joyce kindly introduced, the title of this presentation is Breast Really Best? The Impact of Breastfeeding on Infant Health in a Predominantly Low-Income Population. It's co-authored with myself and my colleague, Kristen Cornelson, who is also in the economics department here at Notre Dame. And also our third co-author is a professor of nursing at Purdue University, Aza Ahmed. So we were interested in this topic, I will admit, prior to COVID. So this is not a study that was initiated because of COVID, but after the pandemic hit, we did become convinced that the intervention and the findings of the study could be even more important and even more influential for low-income populations. Another caveat is that we are not anti-breastfeeding. We are all very enthusiastic about breastfeeding, but I think for Kirsten and myself especially, we're both economists, we're not medical professionals. We were frustrated at the lack of rigorous evidence around breastfeeding. And the more we study, the more we realized that this was a feasible study and something that was very valuable, both academically and also from a public health perspective. So just to give you some background about breastfeeding, anyone who has ever encountered a nursing or a lactation consultant or a mom with a new baby has maybe heard about the wide variety of benefits that are attributed to breastfeeding. So I just came up with a non-exhaustive list. Breastfeeding is widely claimed to decrease many, many bad health outcomes. And here are just, really a subset of the things that you can find if you talk to a lactation consultant or if you look at breastfeeding websites, or even if you look at sources like the CDC. So breastfeedings are claimed to decrease ear infections, infant vomiting, diarrhea, pneumonia, urinary tract infections, meningitis, SIDS, actually decreasing death in infants, infections, asthma, obesity, diabetes, other conditions, even types of childhood cancers. It's also touted to improve benefits for mothers. We are often told that breastfeeding can increase infant maternal bonding. It can decrease rates of postpartum depression in new moms. And puzzlingly, I have often heard that it can improve maternal sleep, and I've never quite understood that one. So what is the evidence for these claims? There is a lot of research on breastfeeding. So in general, the research in the scientific community comes from two types of evidence. The first group of papers use actual chemical analysis of breast milk. So they study the chemical composition, the lipids, the prebiotic factors, the probiotic factors, to hypothesize the actual mechanism of the benefit. So a few of these studies are listed here. Some of them are animal studies where they study different qualities of breast milk in animals and study how the mechanism of transmission of health might occur in animals, and some of them study human breast milk. These studies, of course, do not look directly at infant outcomes. So they don't try to quantify what the actual outcomes are in children, but they are very important because anytime you are positing a causal relationship, there needs to be some type of plausible mechanism for the benefit. So for example, one mechanism that is generally understood for the potential benefits of breastfeeding is that breast milk might benefit the microbiome of infants because it carries beneficial, not just prebiotic and probiotic material, but also actual antibodies from the mother to her child. And this might protect the infant against infection and later on possibly against autoimmune issues like asthma, eczema, allergies, and potentially even childhood cancers. So establishing the science behind those potential mechanisms is very important. As I said before, I'm obviously not a doctor or a chemist. And so I read these as a layperson. And, if you want to dig into the science of these mechanisms, I'm probably not the person to ask.
Sarah, sorry to interrupt, but it looks like your slides aren't advancing.
Oh, I'm sorry. So right now you don't see what is the evidence for these claims?
Right, we're still on the first slide.
Okay. Is it full view for you?
It is not.
You're showing us a PDF instead of a PowerPoint. I'm not sure if you meant to do that.
I did that because
there it is.
PowerPoint generally doesn't behave well for me. Okay, I'll just do it like this without the full screen then. Sorry about that. Thank you for telling me. Okay. So this screen that I'm on is what is the evidence for these claims? Are you viewing that one? Okay, thanks. All right, so I was going over the first group of papers, which is the chemical analysis of breast milk. The second type of studies, and this is the vast majority of studies that are cited when it comes to breastfeeding benefits, are comparisons of breastfed babies and formula babies. These are primarily observational. So there are two ways that these are done. One is retrospective, where they take a random sample of babies, they document their health outcomes, and then they ask the moms questions about their breastfeeding history, whether they were exclusively breastfed, whether they had any breastfeeding, and how long that breastfeeding might have lasted, how much formula was used, etc. There are many, many studies like this, and they vary in their quality, basically. Some of the more high-profile studies are the Horton Victoria study in 2013, which documented an improvement in cognitive skills and an advantage of IQ points for children through primary school and middle school. Loja et al., that's the most high-profile study showing the benefits for asthma and eczema, showing that the group of babies who were breastfed had lower rates of asthma and eczema, and exclusive breastfeeding seemed to offer even more protective benefit. And then Dweet et al. Was a high-profile study indicating a benefit for infectious diseases in babies, both gastrointestinal infections and also other infections like meningitis and ear infections. Our issue with all of these types of studies, the observational studies, is that they don't account for unobserved differences in the breastfed and non-breastfed babies. And a simple way of thinking about this is there are fundamental differences in the types of moms who initially try to breastfeed and also in the ones who are successful in improving their breastfeeding at 3 months, at 6 months, through 1 year. The biggest difference is income. So high income women have a much, much easier time breastfeeding, and you can see it in the data. They're more likely to breastfeed. One of the strongest predictors of whether a child will be breastfed and exclusively breastfed is whether or not the mom has a college education. The reasons for this isn't just that the college educated moms are the ones who hear about the benefits. It's that breastfeeding is quite challenging for moms, especially if they're working. And women in lower paid jobs tend to have a harder time finding time to pump or having nursing breaks to see their baby and to feed their baby. And it's just very difficult for them to continue the breastfeeding. So what is very plausible is that these health outcomes are correlated with things like family income and maternal education, and they're being falsely attributed to breastfeeding. It's also true that both the income, the maternal background, education, and breastfeeding, all these factors might be contributing to these health outcomes, in tandem. But we don't have a way of quantitatively identifying how much of the effect is due to breastfeeding versus these other contributing factors. All right, what is known about the actual causal effects of breastfeeding? There are a small number of randomized control trials, which is to say these are experimental studies of breastfeeding, where they randomly vary the probability of breastfeeding and then look at outcomes in children later on. And because the differences in breastfeeding are not due to things like maternal preferences or maternal education or maternal income, they're just due to a random coin flip, if you will, then we can attribute the difference in the health outcomes directly to those differences in breastfeeding rates. So there are very few of these RCTs, or the randomized control trials, but the largest and most well-known was called a Probit study. It occurred in the 1990s in a group of hospitals in Belarus. So the research design was that they randomized at the hospital level. They had a group of hospitals in the study. They randomly chose a subset of them to implement baby-friendly certification. The baby-friendly certification has a series of policies and practices that are all intended to increase time between the mother and the baby, and specifically to improve breastfeeding rates. So things like they don't separate the mom and baby after birth, they intentionally encourage breastfeeding in the hospital, they don't give pacifiers and bottles in the hospital, and they give the mom information about breastfeeding and pumping and things like that. So the first order effect of the Probit study, which is to say the increase in breastfeeding rates, was very effective. They did manage to increase exclusive breastfeeding rates by about 13 percentage points when measured at 9 months. And there was a strong improvement throughout the whole first year of life in both any breastfeeding and exclusive breastfeeding rates. This variation in the first order in the breastfeeding rates allowed them to look at a wide variety of health outcomes. However, these findings did not correspond to the earlier suggestions about the health benefits. And what they did find is only a small decrease in GI infections and eczema through the first year. They found no causal effect on the other health outcomes they looked at: height, weight, fat content, blood pressure, asthma, allergic diseases through age 11. All right, why does this matter? Infant breastfeeding is literally a universal public health concern. It impacts all mothers and babies. There can be many political and even globally political concerns when it comes to breastfeeding versus formula. A lot of people have interests in formula versus breastfeeding, and I think that mothers and parents deserve rigorous evidence to make these decisions for their children. Secondly, if there are large causal benefits from breastfeeding, I think the most important implication of this is that it could contribute to racial and socioeconomic differences that exist in children. These correspond to differences in breastfeeding rates. We know that low income and minority children in the US are less likely to be breastfed. Specifically, African American children are less likely to be breastfed. And if breastfeeding has these health effects, then it's even more important that we can rigorously identify them so that we can push for different policies, either to compensate or to support breastfeeding in vulnerable populations. I think that COVID has added just another layer of this severity. So we know that the pandemic has really been borne disproportionately by low-income and minority families. In periods of social isolation, breastfeeding becomes even more difficult. And so if there is a further disparity of breastfeeding, it adds another layer of disadvantage for these children that public policymakers need to know about. All right, so what are we going to do? Our intervention will be a randomized breastfeeding study. We're going to use a web-based application called Lactor, which is primarily meant for a mobile phone use, but it can be used on a browser, on a regular computer, or of course on any type of tablet that is web-enabled. The app is very simple. It's basically a diary app. It prompts the moms every day to log all of their feeding activity. So it encourages them to log if they breastfeed, if they pump and bottle feed, or if they bottle feed with formula. They can also have their partner or another family member help them to log activity. And when they log their activity, it also asks, did you have any problems while you were breastfeeding? And if any problems are recorded, for example, the baby had trouble latching, the baby didn't want to nurse, the baby seemed very gassy, the app will automatically send a message to say, try these steps, and prompt the mom to look at educational resources that are also available in the app. There's also the option to chat or message a live lactation consultant, and the app will often encourage moms like, try these steps and then call your local lactation office. So it's increasing activity, not just with the app, but also with the live lactation consultants to make sure the moms are supported. So as we said, for the treatment, we ask the moms to log every day for the first 30 days. If they want to, they can continue logging as long as they want to. As long as they want to keep breastfeeding or formula feeding, they can log for a year, 2 years, 3 years, whatever they want. Most moms they comply with the first 30 days, and it then slowly starts to dwindle off after that. What are we trying to do with this study? Our first order goal is to increase breastfeeding and exclusive breastfeeding rates. There is prior evidence that this app works. So our co-author Aza has piloted this app in smaller populations throughout Midwestern hospitals. They were starting at fairly high rates of exclusive breastfeeding, and we still saw a very substantial increase in the exclusive breastfeeding rate from 66% to 88% at the age of 3 months. Given that we expect to increase the breastfeeding rates, our second order goal is to exploit this random variation in breastfeeding to look at the health outcomes. We're going to look at health outcomes that are most frequently cited for breastfeeding. So gastrointestinal issues, eczema, allergies, and ear infections and other infections. We'll track these at various points throughout the first year of the infant's life. Our community partner for this study is Advocate Christ Medical Center. Without going into too much detail, I'll just give you the key point of this population is that they're very low income. Secondly, there's a high rate of women who are on Medicaid, and Advocate Christ has sort of bought up the Medicaid contracts in this population. And so they are effectively the insurer as well as the provider, which means that they will have both health outcomes for the mom at the time of birth and also pediatric outcomes for the majority of the babies that they supervise.
Dr. Kroeger?
Yes, I'm out of time, I know.
Yeah, please wrap up.
Let me quickly just show you what the app looks like then. So this is the front page of the Lactor application. You can log your breastfeeding attempts, and then once you've logged them, it will give you a history of your breastfeeding over time. And these other tabs, so for example, the tutorials have a video tutorial about how to use the app and also how to breastfeed. The educational materials are a series of PDFs under various topics like jaundice, gaining weight, how many dirty diapers should we see, things like that to help the mom, and then contacts. In the mobile version, there's also a chat function where you can send a message to the lactation consultant. They don't respond 24/7, but they do respond, within one business day for sure. Okay, so I will wrap it up there and let Kathleen take over. Thank you so much. Let me stop my share.
Thank you so much for that great presentation. I would just like to remind everyone that if you have any questions or comments, please type it in the everyone chat box, and we will try to address them all at the end of the second presentation. Thank you. Dr. Sobiech, over to you.
Okay, thank you very much. Thanks for that presentation, and thank you all for your time today. I'm going to go ahead and share my screen. And just let me know if you can see our beginning slide. Can you see that, Dr. Adams?
Not yet.
Not yet. Okay. Did that work?
Yes.
Okay.
Would you like to go into slideshow?
Yeah. There we go. Is that on the beginning script one now?
Yes.
Perfect. Okay, thank you for your time this morning. I will be presenting with Kristen Cornelson. She is a recent graduate from the Masters of Science in Global Health program. And we're going to be presenting the results of Kristen's capstone research project and subsequent manuscript, which was co-authored by Marie Donahue, Maria Alexandrova, and Sherry Bucher. So you can find our final manuscript in the document files for today's forum. So just to give you an overview, I'm going to provide just a very brief background containing information on maternal health in the US, as well as specifically in Indiana, in order to highlight the current challenges. Next, I'm going to briefly present a model of care that illustrates how the role and services of the doula are uniquely situated for addressing these challenges. Then Kristen is going to present our study design and just two aspects of our findings, which we think are important for our audience today. And these are the adaptations made to services during the initial phase of COVID, as well as the implications of our findings for post-pandemic focus on holistic maternal care. So finally, we're just going to kind of bring home two take-home messages for this audience in hopes of getting your input today or in future conversations. So to start, we need to kind of ground ourselves in the US maternal health landscape, and it is not a pretty picture. The outlook is pretty bleak, and this is compared to other developed countries. We are spending a lot of money on clinical maternal health care, and we're still seeing a rise in maternal mortality. So when we look at disparities, the outlook in the US is even more concerning when we examine outcomes for women of color. And this is where death related to pregnancy is 3 times more likely than for white women in the United States. Related to this, the cesarean section rates are higher for Black and Latina women in America, and they make up a little over 35% of live births. And this is contrary to what the World Health Organization recommends, which is more closer to 10 to 15%. And this really leads to increased complications for both mother and baby. So in Indiana, again, the outlook is not good. We're among the worst in the country for maternal mortality outcomes. And despite this, critical need for improving this metric, we do not have policies in place and often find it difficult to pass policies that would protect pregnant women. For example, last year at the state legislature, they did not pass a bill that received strong support from the governor, as well as a strong coalition of partners. And that would have provided workplace protections for pregnant women. And it was nothing overly progressive that was being passed. It was actually a policy that is in place in 27 other states. Again, if we look at disparities, the outcomes for Black women are more dire in Indiana, and it's no surprise that these mothers that are at most risk for poor maternal and infant outcomes are also the most vulnerable to the effects of COVID-19. So this really points to the critical need for including social determinants as we address population health after the pandemic. So then we start to look at the role of doula within the role of doulas in this landscape. And this model draws upon previous studies that highlight the specific roles that doulas, especially community-based doulas, can play in fostering respectful, trauma-informed care free from prejudice. And so these really are points that highlight some of the current gaps that we see in the clinical maternal health landscape, and that's over to the left of the model. And when we discuss community-based doulas, we're really talking about ones that have free services for the population and really come from the communities they serve. And you can look at our paper for more of the discussion about tangible and intangible skills and services that the doulas offer that really are well suited for the gaps in maternal health care that we see in the US. So this is kind of our proposed pathway for improving maternal health outcomes that really focus on the unique skills of the doula. So now Chrissy is going to take over, and she'll take you through some of the experience of doulas, what they experienced during the initial phase of the COVID pandemic, and also the implications for addressing post-COVID challenges.
All right, so hi everybody. As previously mentioned, I am a recent graduate of the Keough Institute, and this summer I had the amazing opportunity to study and work with amazing doulas working and practicing in maternal health. And so I was able to do a qualitative study with my co-authors. And through that, we were able to explore the motivations, skills, and services and adaptations of doulas during and before the pandemic. And so in doing that, we collected questionnaires, we did interviews, and we held a discussion forum. And through those methods, these are a couple of the topics that the doulas gave most discussion towards. And so a few of those adaptations here are listed, specifically the childbirth education. A lot of the doulas were able to customize their own education tools, being it videos, newsletters, exercise sheets, in order to build an intimacy and trust with with those mothers that they were working with, as they were unable to physically hold those interactions as they normally would. A lot of the adaptations were difficult in transition, but the doulas were ready for the various changes that were going on during the pandemic. And so in that, they also use virtual and phone support rather than their normal in-person, very close and personal support methods. And so in doing that, they really encourage their moms and their families to build their confidence and get them to ask their questions and hold their own space, as doulas weren't able to physically be present due to their non-essential status. And so with the virtual and phone support, they also encouraged parents, partners, grandmothers, close friends to help step in with those physical supports, as well as a lot of teaching the physical supports as well as the emotional technique supports that they may normally use in anticipation of not being present, as those policies changed rapidly throughout the pandemic. In addition to that, a lot of the doulas were able to change their models, as the quote below describes. A lot of them crafted packages to best support their mothers that they were working with. And that was vital to making sure that the women were supported as much as they wanted to be and as much as they needed to be during the trying times. We can go to the next slide. And so a couple of the challenges that we encountered and discussed throughout the study, it was a 6-week study. And so a lot of these challenges, although are not new, they were very concerning to the doulas during their stint throughout the pandemic. And so we have systemic racism and stigma, and this specifically refers to out in the maternal health landscape. We're specifically referring to the barriers and challenges created, faced disproportionately by mothers of color throughout their pregnancy, delivery, and during their postpartum stages. And these include provider choices, where they're able to seek services, whether they have a midwife or an OBGYN, and the choices that they have available. In addition to that, we had several Black doulas, doulas of color, that were able to share their stories and their personal poor maternal health experiences and what that meant for their professional perspective and how that suited them to better support the moms that they were supporting throughout the pandemic. This is also an example in the quote below. We also had doulas that supported mothers during the pandemic where we saw where they were seeing, even during the pandemic, which is already a difficult time, where they were already seeing even worse treatment. One particular story, a young Black couple was threatened to have CPS called during their stint in the hospital because of possible drug use with no history. And so those were stories that the doula shared with me, and we're trying to figure out how to best fill those gaps and what they needed to do. In addition to that, as I kind of mentioned before, access to services refers to not only maternal health services, but also doula services. As doulas, the wide health landscape is not actively pushing doula services. So some people don't know about them or aren't sure of what a doula is, and it kind of snowballs from there. And so the client pool is also smaller. Yes,
we'll
ma'am.
wrap up.
Yes, ma'am. There's also, and so for our take-home messages, we have two very important messages here. Going back to the model of change, we have doulas creating this pocket where they are filling those gaps in maternal health spaces, where they can elevate and amplify women's voices and improve their overall maternal experiences. as well as questions and certifications, trying to not create a homogeneous community and allowing those different experiences to emerge. Thank you guys so much for coming.
Thank you.
All right. Thank you to both presenters for such great presentations. We would like to dive into the Q&A session. We have just about 6 minutes for that, so we'll try to answer as many questions as we can. The first question goes to Dr. Kroeger and is from Kathleen Sobiech. She's asking whether you have looked at premature infants versus full-term infants.
Yeah, so no, our study is only for infants born at term. There are very clear differences for breastfeeding, or there are very clear benefits for breastfeeding for preemie infants. And I believe that, I mean, most hospitals now do their best to exclusively feed preemie infants with breast milk and not formula. So we certainly, you know, we wouldn't want to come in and implement a study where like some of the preemie infants were being fed with formula, because we know that they have a hard time digesting the formula. Thank you though. Yeah, so this is more for babies who are born full term and full birth weight.
And we have a question for Dr. Sobiech, and it's, let's see, how much variation is there in the approach of different doulas? So for example, cultural differences and other variations in the care that they provide.
Yeah, really the focus of the doula is on the mother. So their ethos is very strong about where they are coming from. So I think they try to be more responsive. It's more the question of the culture of the mother, and the doula is constantly trying to be aware and respectful of that culture. Would you agree, Chrissy? I see you shaking your head. Right. Yeah, this is what I think Chrissy had some doulas that specifically mentioned their training and how to be culturally appropriate in different situations. And that's also why we think community-based doula programs are important. Doulas that are serving the communities they're from is a really important aspect of that model.
Thank you. And there's another question on breastfeeding, and it's from Gina Wilson. And her question is, how does social isolation make breastfeeding harder? I would have thought that it would make it easier.
Oh yeah, so this is an interesting question. So breastfeeding, although it is, you know, natural, doesn't come naturally for many moms and many babies. And surprisingly, many babies actually don't know how to suck properly or effectively. And it can be very overwhelming for a mom who has no experience breastfeeding to figure out how to do that on their own. Most hospitals now, especially the ones who are baby certified, as someone pointed out, like most of the ones in South Bend, I mean, the two main health systems in South Bend are baby friendly certified. They provide lactation consultants because a large majority of moms do need a little assistance at the beginning. Even if there's no physical problem with the mom or the baby, just the mechanics of breastfeeding can be tricky. So there's that initiation that can be very helpful with support. And then secondly, it's just a lot of hard work for many moms. Like physically, it's hard work, and it can be very gendered because, of course, only the mother can do the breastfeeding, and so it can be hard for the partner to know how to support her. So when you're not able to go to lactation clinics or lactation support groups or see your other moms who are breastfeeding, I think the lack of logistic and emotional support can dampen breastfeeding and make breastfeeding success more difficult.
Thank you. We have another question from Dr. Maria Alexandrova on breastfeeding, and it says, are you going to explore enabling factors to establish exclusive breastfeeding since the first 2 weeks of neonatal postpartum care are mostly essential for breastfeeding? And since your targeted population sample is low income women, Are there going to be, will you provide breast pumps, bottles, etc., particularly for women who return to work?
Yeah, so this is a good question. We don't provide anything outside the app. The app it's a very light touch intervention. In a way, it's surprising that such a light touch and low cost intervention can have such a big effect on the first order outcome, which is breastfeeding rates. Are we going to study I think it was the other enabling factors? So one advantage of doing it within one large hospital system is these women all have comparable starting points. Like they all have the same information when they're in the hospital, and they're all more or less leaving with the same resources because they have the same lactation clinic to call. If we do it in a different setting, we would want to record like differences in the environment at the hospital and those initial enabling factors. So one important thing about this intervention is that we do try to initiate it at birth. So it's when the lactation consultants go and do that very first visit with mom in mother-baby unit, they say like, here's a pamphlet on this app. If you're interested, you can email these researchers. They'll set you up with a code and you have access to this app for as long as you want it. It's your choice. You can use it or not use it as you want. I think I might be forgetting something. So if we're studying it within one large hospital system, we don't have the scope to look at differences in things like having a lactation clinic on site versus not. It's purely the effect of the app. The point of this study also I want to stress is not so much we're studying like the best way to improve breastfeeding. It's just that we happen to have a very low cost, low touch way to improve breastfeeding. And we're exploiting that to look at the causal effects of breastfeeding. So it's really those secondary health effects that are like the big contribution of the study.
Okay, so let's take one last question and a comment. Okay, and it's asking whether you'll be looking at proximity of the baby to the mother when breastfeeding. So like sleeping in the same room versus sleeping in a different room and then the mother having to wake up and check on the infant. And there's also a comment about comparing mom and baby diets in preemies versus full term, who might be interested. That might be interesting since those who spend time in NICU generally get far more education than those who do not. So if you can respond to the question about looking at the proximity of the mom and baby, and also if you'd like to respond to the comment about looking at babies in preemies versus full-time.
Sure. So because this study is very focused on the effects of breastfeeding, not on other sleep habits, I think we will record. That's a very good point. I think that's something we should add to our initial intake, right? Like, where does baby sleep at night? Where does baby sleep at nap time? There's not a ton of variation in this population. Most of them do live in quite small apartments on the south side of Chicago. So we do see a lot of babies sleeping in the same room as their parents or their mom, just for convenience reasons and for space reasons. But at least recording that is useful, I agree. With preemies, yes, I do acknowledge that large disparity in the information that parents of preemie moms get, or that parents of preemie babies receive. And our study only focuses on full-term infants just for that comparability between different mom and baby dyads, as you said.
So I would have loved for us to continue this discussion, but we also need to respect time. And so we'll need to pause at this point. I hope that we will continue the discussions, the conversations, even outside of this panel, and that, there will be future collaborations for research and improving maternal and newborn outcomes. I would like to thank everyone for making the time to attend this session, and thank you to all of our panelists for your expertise and time.